Welcome back to the this lesson. And today, as I promised, I am talking about the role of surgery in peptic ulcer and its the indications and the role. And we will always stick to the basics. Now, whenever we get a patient with suspected ulcer, if it is upper GI bleed or perforation or regardless, we need to do the usual assessment. And the usual assessment is that we check their vital signs, we ensure their hemodynamic stability, check their hemoglobin level and their renal function, which is essential in this situation. We also need to check their coagulation and check whether they are actually an anticoagulant. In this day and age, we have an increasing number of people who are being anticoagulated for a variety of medical reasons, notably AF and valve replacement. Patient get resuscitated on the usual guidelines of the ABCD. They might need blood transfusion, and you immediately start giving them a bolus of 40 milligrams of pantoprazole and then an infusion. Obviously, if they are stable, they will have an endoscopy, and this is an example of a duodenal ulcer. That's how it looks on endoscopy. Duodenal ulcer in the first part of the duodenum. The surgical indications that we need to understand in relationship to peptic ulcer are the following. The most common two are bleeding peptic ulcer and perforation, regardless of whether gastric or duodenal ulcer. Very occasionally, and less common these days, after the H. pylori eradication and the PPI era, we see gastric outlet obstruction as a result of recurrent duodenal or antral ulcer that lead to scarring and non-healing, and that lead to gastric outlet obstruction, which is characterized usually by dilated stomach and vomiting of undigested food. Also, loss of appetite and early satiety. Very occasionally these days we see intractable ulcers for no reason that is discernible. But it's again a rare disease, but still does exist and is an indication for certain form of surgical treatment, usually in the form of gastrectomy. There are very unusual occasions where gastric ulcers just do not heal despite all the factors that we put in the treatment that we implement. And one example of recalcitrant gastric ulcer that doesn't heal is in people who have celiac artery stenosis. The stenosis has to be significant, more than 50, and that impairs the blood supply and also impair the healing of the ulcer. Occasionally in people who are smoking, their ulcer may not heal properly. Now, once the patient is in the hospital after giving them the PPI and the first line management, then they will get an endoscopy. And endoscopy here is going to be diagnostic as well as therapeutic. And it's possible to control the GI bleed in these situations in up to 75% of the cases. And there are a variety of methods that can be implemented. The ulcer sides could be injected with saline with adrenaline, and the effect of the pressure and the vasoconstriction with adrenaline is the causative factor that help to stop the bleeding. We have argon coagulation beam that is useful for superficial ulcers. There are hemostatic products. Again, these are useful for oozing ulcers that are superficial with no involved blood vessel. However, if there is an active arterial bleed that is seen on endoscopy, then the endoscopist can apply an endoclip via the gastroscope, and that tend to be effective to control the bleeding. Now, every now and then, the bleeding will occur, or the vision inside the stomach and the duodenum is difficult due to large quantity of blood, or the blood vessel is that's bleeding is seen but wasn't possible to control. Then we will proceed to the operating theater. In the duodenum, these ulcers are usually posterior ulcers eroding into the gastroduodenal artery, and we do a midline laparotomy and anterior duodenotomy. We open the anterior wall of the duodenum, and just with a stitch, we run underrun the vessels to control the bleeding. Just like getting any bleeder usually is the most effective technique. There are other techniques, but to avoid the confusion, we just stay now with ligating the bleeding vessels, which is the gastroduodenal artery. Patients will be on PPIs as well to for the operation to be effective to lead to the healing process. If we have gastric ulcer, then the treatment is different. Usually, in this case, we need to do a distal gastrectomy, or what's called antrectomy, which means that we are removing the stomach from the pylorus up to the body of the stomach. So it will be the pylorus, the prepyloric region, and the antrum up to the incisor. And these are the most common sites for gastric ulcers to bleed. And then the stomach gets reconstructed in what's called Billerud 2 type of reconstruction. You see here the blind end of the duodenum sutured, and a loop of the jejunum brought up to the stomach and done in a direct anastomosis. There are other forms of anastomosis that could be done, but we will leave that for now. The next most common complication that need surgery is perforation, and that's in particular with the duodenal ulcer that's lying in the anterior wall. Anterior ulcers perforate, posterior ulcer bleed. These people present with sudden onsets of abdominal pain. They have rigid abdomen. They are unwell, and when you do their blood, they have got raised white cell count and inflammatory markers. Also, if you do a CT scan for them, you will find free gas under the diaphragm, and that will clinch the diagnosis for us in most of the situation. However, very often the clinical signs are enough to make the diagnosis and to justify operating on the patient. After resuscitation and trying intravenous antibiotics in the form of either tazocin or ceftriaxone or any other form of broad-spectrum antibiotics plus PPIs, we take them to theatre. Now, what do we do? The operation here depends on the type of the ulcer. No huge big difference, but still there is a difference between the gastric and the duodenal. For duodenal ulcer, we do close the anterior wall, and we reinforce the closure with an omental patch and leave a drain next to the closure line. The patient will need to be on PPIs, and H. pylori eradication is needed. If the ulcer is gastric, then we should take a biopsy, because perforated gastric ulcers could be malignant. And then we close the ulcer in a similar fashion with an omental patch. And these patients will need, in addition to H. pylori eradication and PPIs, they will need to be brought back for a gastroscopy in 6 weeks' time.